Hello and welcome. This is your brain on drugs, and this is the punk rock psychiatrist. So today I'm actually pretty excited. I know I say that a lot, but I'm excited because I'm talking about bupropion, which is one of my favorite medications, I would say, for the treatment of depression and anxiety. And I think maybe that's not the case with everyone, and especially like I think the history of it. There's some interesting things. So this is a good one. This, like I said, I think for a typical patient, I'll often reach for escitalopram or bupropion, maybe Cymbalta, duloxetine. So those are some of the ones I like to use the most. But there's a lot of reasons why I like this one the most, and today we're going to talk about it. So first, you know, I've been, as we've been going through our medications, I note whenever when we talk about a medication that is in the top 300 prescribed medications list, and this is one of them at 21. So just behind trazodone at 18 and above fluoxetine at 22, as far as mental health medications are concerned, it is kind of right in the middle of the common antidepressants, beat out by sertraline Zoloft and escitalopram Lexapro. So looks like it's about the third most popular antidepressant, and I'm kind of happy to see that because like I said, I do like it. Um, so one thing, let's talk about how it works. One thing I wanted to mention is that we call it bupropion, but up until it was approved in the year 1985, and then it became generic, and its generic name is bupropion. Its brand name is Wellbutrin, but 15 years later, in the year 2000, it was actually when it was named bupropion. Prior to that, it was known as amphibutamine. So, if any of you were around at that time, I was not. You may remember it being called amphibutamine. Bupropion was the new name. So, let's look at its mechanism of action. It's got some interesting features in its mechanism of action that really it's really unique. There's no other medication that's approved that quite does the things that bupropion does. It is not the only norepinephrine dopamine reuptake inhibitor, but certainly the only one approved for depression. Now, if we want to think about some other NDRIs, there is methylphenidate and amphetamine. And Wellbutrin, bupropion, is actually also um, like the amphetamines, like Adderall. It is a substituted amphetamine, and so it has the NDRI capability that the ADHD medications do. Now, a lot of you are probably familiar with maybe using it first line. I know a lot of, it's not really a first line medication for ADHD. I've seen it listed fourth line, but to me, it doesn't make a lot of sense to list it fourth. I mean, methylphenidate and the mixed amphetamine salts, they're typically listed first and second, but they're also the most effective. If those don't work, the chances that bupropion is going to work is really, really poor. I'll often see atomoxetine Strattera listed third, and bupropion maybe listed fourth or fifth. Clonidine sometimes thrown in there, um, but it's less that you would use it after you used one of the stimulants. It's more you would use it instead of, because you were worried that maybe the patient was going to abuse a stimulant, or that maybe they didn't have ADHD, but they were very persistent in asking for something. And in order to not tell them no, you didn't want to do it, you said, well, let's try this medication. So that, I think that's what I see most commonly, is that patients are kind of like, oh, I don't, the provider's like, I don't think they really have ADHD, but they really want something. And I think maybe this is more of a depression anxiety component. So I'll give them the bupropion and I'll tell them that it might help with their ADHD, but I'm really hoping that it works as a placebo, or that really it's not ADHD that they have, but it's more of an anxiety or depression, and maybe it'll help with that. So that's kind of how we use it. If you actually thought somebody had ADHD, this would not be a medication that I would really ever consider using. Um, there are some other things you can do if there's some abuse concern. this would not be something I would do in that case. There, like I would use maybe a Vyvanse or something. There are other options. We'll talk about those when we go over ADHD medications. Um, but yeah, so it does block the reuptake of norepinephrine and dopamine like the stimulants do. However, it does not do it as potently. Um, the mixed amphetamine salts are dope. They release their dopamine releasing agent. They're not just a reuptake inhibitor. And then methylphenidate, it's a much more balanced norepinephrine and dopamine reuptake inhibition. Bupropion doesn't doesn't do much on the dopamine. It's more strongly norepinephrine at max or at medium dose of 300 milligrams. You're maybe occupying 50% of the norepinephrine transporter and maybe like 20% of the dopamine. So, is that enough to really affect dopamine? Might you go up to 450, the max dose, and have more of an effect? In patients I've gone up to 450 on, I've not really noticed much difference between 300 and 450. But, some people might have some additional effect. The atomoxetine, which is a pure NRI, doesn't really work well for depression. This does. So my inclination is that there is some dopamine reuptake inhibition having some effect, though there is some controversy over whether that's the case. There definitely is norepinephrine reuptake inhibition happening. All right. So that's its main function, and the drug is known as an NDRI, but it actually has several other mechanisms of action that are quite intriguing. And you're probably familiar with these, especially the next one. It's a non competitive antagonist of nicotinic receptors. All right. You've heard of Zyban, the branded product used for smoking cessation, or of course you can use the generic Bupropion SR, which is the product that's approved for smoking cessation. It actually works fairly well. I've given this to a lot of patients for smoking cessation. Um, I'd say more what I notice is that they decrease their nicotine use, and it's not maybe so much that they completely stop. Um, I don't work in a clinic where that's all we do, so I'm sure those of you out there that maybe are purely doing a lot of this maybe have seen some complete cessations from bupropion. But what I notice is that maybe they cut down by half or more. So good, any less use is positive. And I often, when I'm screening someone for giving them this medication, I'll ask if they are a nicotine user. And that's not just tobacco. Of course, that also would include vaping and also other tobacco products. So, chewing tobacco and things like that, not just cigarettes. So I'll ask them that and I'll say, hey, well, I don't know if you're thinking about quitting, but you may notice that this helps you stop. I've had patients that I forgot to say that to that came back and they're like, I'm not smoking as much as I was before. And then I'll tell them, oh yeah, it's because of this. Right. So if they're actually trying to smoke or stop smoking, this could help, right? This could help them stop. Like if you're not trying to stop, you may just not crave it as much, but still do it because it's a compulsion and maybe it hasn't gotten rid of that urge completely. But if you're actually trying to quit, this will help, and it might help enough to help you quit. So that's a great function. I personally think that Chantix does the best job for smoking cessation. I think it's an amazing medication. I've had great results with it. We'll have an episode on smoking cessation where I'll go through all of those products. But this is not bad for that, and it could be an added benefit. And that's another thing. If I've got a patient that I'm considering what antidepressant do I want to give them, and they're a nicotine user, I'm going to think about this one first. I think I know the SSRIs are often, listed as the first line medications, but if you got a patient that is a nicotine user, that may be a reason to bump bupropion up. I actually have a lot more reasons to bump it up in the list, but that is a good one. So there's actually some other mechanisms of action that it has. So it also activates the pro-opiomelanocortin, POMC neurons in the hypothalamus. That's a long word. What does that mean? Right? That's where we get the appetite suppression. Now, those of you that have given this to patients, you probably noticed that they often have appetite suppression. And there's warnings not to give it to people that have eating disorders like anorexia and bulimia. One reason is because it could increase the risk of seizures, particularly with anorexia, but with bulimia, it could, feed into their eating disorder. So those would be patients that you would not give this medication to, right? But many of you may be aware that there is a product combination pill with naltrexone that is FDA. It's called Contrave, is the branded name. Bupropion, naltrexone. It's approved for weight loss. I have used it several times, especially before we had the GLP-1s. I used to use this combination a lot, and I would notice about a 5% weight loss, maybe 8%, maybe like 10, 15 pounds for an average size person. Not amazing. It's, we have way better stuff now, but when a lot of other medications cause weight gain, especially SSRIs, this one does not, and can actually cause you to lose a little bit of weight. That, it's not going to make somebody who's obese in a healthy range. I highly doubt that. But if you've got someone that's a little bit overweight, or there's some concern that they may gain weight with medication, or, they're already a little bit overweight, this may be a good choice, so that, you don't make things worse, because it'd be very rare for them to gain weight on this medication, right? So even though there's not a whole lot of weight loss, maybe if you add naltrexone on it, there could be a bit more. You're not gonna have more weight gain, hopefully, right? And then there's another feature of this medication that maybe those of you out there, smart folks, you knew about the NDRI, you knew about the nicotinic receptors, and you knew about the weight suppression. Maybe you didn't know exactly what receptor in the brain was causing that, but you knew about that. But bupropion also has anti-inflammatory characteristics. And it's not completely understood. It's thought that maybe it could reduce TNF alpha. There may be some other things. And, I've listened to some talks. There's a lot of folks out there that have done some research that there's certain types of depression that are related to inflammation. Now, I've chosen the antidepressants to be the first medications that I cover because they are the most common. Remember when we went through the list, like almost all the medications in like the top 300, especially in the top 100 that are mental health medications, almost all of them are antidepressants. Let's see, I've got the list right here. Only Adderall and methylphenidate, Xanax, Buspar, Klonopin, Lamictal, Ambien. So there's a handful, but the ones in the real top 50, almost all of them are antidepressants. So I thought it'd be most prudent to cover the most prescribed medications first. The unfortunate thing is these are also like, although the placebo effect is quite good, the actual like drug effect is some of the worst of all of the mental health medications. I much prefer to treat bipolar disorder or schizophrenia or ADHD or something like that, where the treatments that we have are quite effective, and they perform better than placebo to a much higher degree than the antidepressants do. And so it's kind of unfortunate that that we don't have better treatments, and I think that's why a lot of folks are looking for like other treatments. And we've got a lot of new stuff that's come out. We've got the NMDA receptors antagonists, and we're going to talk about those in a few episodes. There's some other medications we're going to talk about what's on the horizon. Once we get through all the FDA approved ones, I'll talk about like what's out there and what may be coming down the pipeline. The problem with depression is it's not clearly understood what the cause of it is. If you want to hear the whole talk on that, this is a very early episode that I did where I talked about where depression kind of chemically and biologically is what's happening in the brain with that, but it's not well understood. And generally, it's like all psychiatric disorders, it's a symptom, it's a syndrome, which is a composition of symptoms, which is unfortunate because that means that there's not one thing that causes depression. There's many things, and we don't really know what those are. There are types of depression that are probably more akin to bipolar disorder and might be more responsive to something like lithium. There are types of depression that are more, situational relationships, work related, more of an adjustment disorder type of thing, but they, meet the criteria for major depressive disorder, even though I probably would not, I mean, per DSM, but like I probably wouldn't categorize them in that way. So you've got a lot of social issues that can cause depression. And then there's some thought that there's an pro-inflammatory states that can cause depression. And I'm going to talk about the bupropion is one of the treatments that's kind of listed. Um, Increasing dopamine. So, I mean, you could use the stimulants, you could use a pramipexole, you could use a bupropion, and that might help because those medications have some anti-inflammatory effects. And one thing you can do is if you're having someone that is not responding to the treatments, you could check a CRP if it's over a certain amount. I think it's like 2 to 3. Like I said, I'm going to talk about this later, but this is another avenue for bupropion. Now, I don't really think this is that groundbreaking of an idea at this point because I'm probably giving people bupropion first or second anyway. And so did I really need to check their CRP and like, oh, I'm going to give this person bupropion because of this? I was probably going to reach for it first or second line anyway. And so it's not like I would never have gone this direction, right? So, but interesting is just an interesting thing. And another great thing about it is there's no blockade of alpha 1, no blockade of the muscarinic receptors, no blockade of the histamine receptors, and no serotonin reuptake pump inhibition either. So, this medication came out in 1985, so shortly after trazodone. And it's even basically, trazodone came out because we wanted something that was not anticholinergic like the TCAs were. Well, this also doesn't block histamine or alphas or the serotonin receptors at all. So we've got something that's even cleaner. And so this was really a breakthrough in 1985 when it came out. And then Zyban was approved in 1997, which, like I said, is the same product, but Zyban is only the twice a day product. And then Aplenzin, and then 450. And I'm going to talk about all these formulations in a second because there are a lot. There's a lot of formulations of bupropion. So next, what are the actual clinical uses? I've kind of talked about this. FDA approved uses: depression, smoking cessation, seasonal affective disorder. Off-label used for ADHD, like I mentioned, though I don't really like its use for that. Off-label use for neuropathic pain. I think we've got better options for that. I'm thinking something like pregabalin or duloxetine. But if you've got, you may get that effect as well if you're using it for something else. And then weight loss, as I mentioned, and the treatment of sexual dysfunction. And I've talked about those before. So I just talked about weight loss. It can cause weight loss. There is the FDA approved product where it's combined with naltrexone. And then sexual dysfunction, I did 2 great episodes. I think they're pretty great. They're 2 of my favorites because I really think the sexual dysfunction is a huge issue when we're dealing with these antidepressants. And so it's something really important. And it's one of the things that concerns patients the most is take these medications. I see Wellbutrin used to treat sexual dysfunction a lot when it's SSRI induced. So they'll add this on top. I don't get a lot of good effect from this. Now, if you're doing what would be a better technique would be use this instead of the SSRI. So if you're having an SSRI induced sexual dysfunction, if you get rid of the SSRI and use this, you won't get that issue. But if you've got someone who just has sexual dysfunction, this is probably not going to help that much. It just and actually the manufacturer of this drug got in trouble. They were kind of promoting it for use of treatment of sexual dysfunction and weight loss, and they were fined $3 billion for it for false marketing. So, I mean, and that may just be because they don't have the approvals for it, but it also is probably because it doesn't really work, right? Like I said, combined with naltrexone, you get very meager weight loss. On its own, even less, right? And this, like I said, the sexual dysfunction, I think if it's a SSRI induced sexual dysfunction and you're replacing it, right, great. But if it's just, that's just their issue, then it's probably not going to do a lot. All right. And as I mentioned before, it is a substituted amphetamine. That's concerning for a lot of countries. It's not really concerning for me. So Russia's actually banned it and called it a narcotic. And Australia, France, and the UK have said that they only approve of it for smoking cessation. A lot of places, there's been a lot of concern about bupropion, and we're going to go into those concerns. And I've been in Japan a long time, and the Japanese, it's not approved here at all. Um, I don't know that it's because it's amphetamines are actually illegal substances in Japan, prescribed or otherwise. Methylphenidate's approved. It's not used a whole lot, but the amphetamines are like no good. This is not an amphetamine. It's a substituted amphetamine. So I think they sought approval but didn't get it. But in the United States and Canada, this is where most of you probably are. This is something that is out there and available for use. So let's go through all those formulations. I've already kind of touched on it. There's a lot of interesting points in here. So there are two salts. You've got bupropion hydrochloride and bupropion hydrobromide. So let's go through the bupropion hydrochloride formulations first. You've got immediate release, it peaks in 2 hours, and the way you can dose it is 100 twice a day or 100 3 times a day, and the max dose is 450 milligrams divided either 3 or 4 times per day. This product can be split and crushed. The rest of the products cannot be. They can be split. They can actually be split. The long-acting products can be split, but they cannot be crushed. So you can't chew them, but if you needed to like cut them in half or something, depending on whether they are capsule or a tablet, it might depend on how you could be able to do that. But the next one that came out was the sustained release product. This is Wellbutrin SR, sustained release, and Zyban is also this product. Now, the pricing of bupropion is interesting. So the immediate release pretty cheap, about $1 a pill. But when we move into SR, the branded product is $10 a pill. The generic is $1 a pill. All right, so big difference. We don't really need to use the branded product. We have the generics available. Peaks in 3 hours. You can do either 150 milligrams a day or 150 milligrams twice a day. So I think of immediate release as something that would be dosed 3 times a day, but manufacturer says 4 as well, but typically 3. Sustained release is twice a day, and the extended release is once a day. All right. So, like I said, SR can be split, but if you split it, swallow it whole. Next product is the extended release. This is Wellbutrin XL, and you're probably wondering if it's extended release, why isn't it XR? Well, XL stands for extra long. As far as I'm aware, XL and XR have the same meanings. Now, DR, CR, those have different meanings, but XL and XR, I don't know why you would pick one versus the other, but maybe they think Wellbutrin XL sounds better than Wellbutrin XR. Now, this branded product is $100 a pill, but there is a generic, and it's $1 a pill. So that's a huge difference. It peaks at 5 hours, and you can take 150, 300, or 450 milligrams in the morning, right? Now, with the other ones, one of the side effects, and we're going to get into this, is it can disrupt your sleep. This has got somewhat of a stimulant type characteristics. So when you're taking the 2 or 3 time a day formulations of this medication, you're not going to want to take that SR every 12 hours. You're going to want to take the first dose early, and the next one probably 8 hours later, right? We don't want to take it too much later, or it's going to keep us awake. And the immediate release, like I said, I probably wouldn't do it every 8 hours. I would probably scrunch that up so that we did not have a dose that was that close to bedtime. With the XL, of course, it's only dosed once a day. We don't have this problem, but this is a med that you want to take in the morning. I don't think I mentioned this when we talked about the SNRIs. Dose the SNRIs in the morning. They both have the norepinephrine characteristic. So these are pills to take in the morning. The SSRIs, some of the other antidepressants, they can kind of go either way. It depends on the patient. I've had patients that prefer to take SNRIs at night, and they did better that way. Most people, it's better to take in the morning. Bupropion, pretty universally. I may have had 1 or 2 patients ever that said that they like taking it at night, but this is one you're definitely going to probably want to take in the morning because it can keep you awake, which is one of the issues with it. All right. So that's the XL. And then the last of our bupropion hydrochloride formulations is the extended release product 450. That's spelled FORFIVO XL. Now, if you say it slowly, 450. This is actually a product that comes in 450 milligrams, 450 milligrams. They kind of a cutesy name. It's pretty expensive, $20 per pill. It's not generic at this time anyway. 450 came out in 2011. And there's no generic product of this as far as I'm aware. There might be now. I think when I looked through the list, there is a 450 milligram pill. So you may be wondering, why do we even need this 450, right? So sometimes patients will be taking the max dose of 450 milligrams. For some reason, Wellbutrin and the generics of Wellbutrin didn't make a 450 milligram product. So you had to take a 300 and a 150. And I guess, taking 2 pills is more onerous than taking 1. Now, if that pill cost $1 versus $20, I think you would, I guess it'd be $2 because you use 2 different pills. So one 150 milligram pill and one 300 milligram pill at $1 each, even less, would be $2. Probably not. Is it worth it to you to take a $20 pill to get, to only have to take 1 pill a day? Probably not. And not a lot of people take 450 milligrams. Not a lot of my patients, or not a lot of the patients that I've seen that have seen other folks. So I don't know how much of an issue this was that we needed to increase the price tenfold in order to get a product where it was only 1 pill. Seems kind of silly to me. It seems like kind of a gimmicky product. And how easy is it to just create, let's just make a pill that's 450 milligrams, brand it, give it another name. This is one of many of the drug companies' tricks. I mean, they're already gouging us. We're already paying like 3 to 4 times the price of the products that other countries pay for the exact same medications, because a lot of the, even though a lot of these companies are actually not based in the United States, I think that's something I used to think was that, all these drugs are made in the United States. Well, they're not. Novo Nordisk, I believe, Novo Nordisk is a Danish company. GlaxoSmithKline, I think, is German. AbbVie, I think it's German or British or something like that. A lot of these companies are in Europe, but yet for some reason, our political system in the United States has made these pills cost a lot for us. And so do we need it to cost even more just so you only have to take 1 pill, or so that you take a branded product versus a generic? Let's, not do that. Our medical system costs enough as it is. All right. So I've never seen 450 used, and I would not recommend it. There's really no benefit to it. And I do believe there is now a generic product that comes in a 450 milligram pill, but where I used to work, it wasn't in our formulary. So it may not be available as much as the 150s and the 300s. But like I said, how many patients are on 450? Not that many. Can they take 2 pills? Yes, they can take 2 pills. All right. And then our last formulation is a bupropion hydrobromide. So this is a different salt. The branded name is a Plenzen, came out in 2008. And it comes in some unusual doses because because hydrobromide weighs more than hydrochloride does. The pill sizes are different. So a 174 milligram is equivalent to 150 of the hydrochloride. 348 is equivalent to 300, and 522 milligrams is equivalent to the 450 milligram dose. Now, here's the kicker. This stuff is $100 to $200 per pill. That's pretty insane. And I don't really know what the benefit here is. I think when it was out, I was hearing, before 450 came out, this was another option to have 1 pill at it's 522 milligram dose, but what most of us would think of as the 450 milligram dose. Bromide does have some anticonvulsant properties, and I'm going to talk about the seizure risk with bupropion. So perhaps, there was this thought of, well, people are concerned about giving bupropion because it can cause seizures, and hydrobromide has some anticonvulsant properties. So maybe in patients that have some seizure risk, or like some prescribers who are concerned about seizure risk, they might be more likely to prescribe this product. However, this point is still not proven. Like, bromide does have anticonvulsant properties, but when they tested the medication for approval, it's not like they said, "Oh, this does reduce your seizure risk." That was, I don't even know if they try and sell it like this. I've never seen a patient on a Plinzin. You know, that's why you come to this podcast. You come to this podcast to learn about every single drug that has ever been out for mental health, or is currently out, so that you know what it is, and know, whether you should gravitate towards it or stay away from it. And I would stay away from this because I just don't see any benefit to it. Let's just, I listed a whole bunch of formulations. What product do I like? I like bupropion extended release. That's the one I like. The once a day in the morning, take one pill, and if we have to do 450, then they take two pills. This is that, to me, once a day pill, or is, even if it's two pills once a day, it's once a day, easier for people to remember. That's the one I go with. I've seen a lot of people take the twice a day one. Um, I've actually heard that some people respond better to it. So I wouldn't, I the 3 time a day one, if you've got someone who can't swallow pills, that's why you would pick that one. I've heard the SR for smoking cessation. If you're giving for smoking cessation, technically you kind of have to use this one. I usually just give them the XL anyway, and basically, I guess we pretend like they have depression or anxiety as well, which they probably do. If you're a smoker and you're trying to stop, you have anxiety, boom, I can give you this medication, for something like that, right? Or you're depressed because you can't smoke. I mean, you could just to give them a pill that's once a day. And the XL used to cost a lot more than the SR. Not so anymore. Now we have the generics. It costs about the same. In fact, it's probably cheaper because it's only one pill instead of two. Because SR, of course, you have to take twice a day, so it's two pills a day instead of one pill a day. So I give pretty much everyone the XL. That's what I do. I like the XL. I've had good success with it. That's the one that I like. But good to know about everything that's out there. So next, I want to talk about the adverse effects. Now, the main ones that I see, I already mentioned insomnia. It is kind of got some stimulant properties. It's got that norepinephrine. It can kind of like raise heart rate, raise blood pressure, and so that can make it hard to sleep. It does, even though it's not approved for ADHD, I said it's not great for ADHD, it can kind of have that same kind of side effect where it's kind of a little bit stimulating. Even if it's not stimulating enough to improve your concentration, it could be stimulating enough to prevent you from sleeping. So that could be a reason why someone wouldn't be able to take this medication. Give it as early as possible. And this is another reason to use the XL, because then you have all the medication as early as possible, right? It's a little more tolerated that way. Next one, agitation. So I've had patients that get kind of ragey on this. Like they get more angry, more fights with the spouse. And maybe if this is a person that's already kind of prone to that, maybe they take it one step further, which is a step that we don't want it to go. That could get violent or dangerous. I have seen that from time to time get to that point, but just the more irritability, that would be a reason why, if that happens, that I would probably switch them off of this medication. And then the next one is jitteriness. They feel kind of shaky. That they say they feel jittery, right? Just they're just shaky, and like their mind's kind of moving, and they just feel uncomfortable, right? Those are the three big ones. If somebody, if I give them the medication, they get insomnia, agitation, jitteriness, that may be a reason. If we give it another month, see if it gets better, but if it doesn't, we may have to come off of it, right? And then the rest of these are a little bit more minor. So you could get headache, but that's with pretty much any antidepressant. Nausea, More likely with the serotonergics than with this one, but it could happen. Rash, I mean, that's with any medication. I maybe have seen a rash one or two times in this medication. Seizures, I'm going to have two full slides where I talk about that. It's pretty rare, but like we'll talk about that in a second. Weight loss, you've got someone you don't want to lose weight, that doesn't want to lose weight, that is losing weight. You're probably not going to lose that much, but it could, that's the average. Some people might gain weight on it, and some people may lose a ton of weight on it, right? So something to be aware of. And then the increased blood pressure, that could be an issue. And that's an issue with the SNRIs as well. That's that norepinephrine. So it could push them up into a point where their blood pressure is in a area that we don't want it to be in. If the medication is working really well, I probably wouldn't take them off of it because of this. Maybe I would try an SSRI if they hadn't already tried one. But if they had, or we did, and it didn't work, and this was the medication that worked the best for them, I'd probably just treat the blood pressure. Yeah, I'd probably just treat it with a medication because, if having depression and anxiety is so miserable, and if it makes you feel really awful, then better to take a medication if it's working to help it, and then just treat the side effect. I prefer not treating side effects, but like I said, if that's our only option, we'll do it. So now I want to dig deep on seizure risk, because this is the thing that, especially folks that have been around a lot longer, especially folks that were around when this medication was first coming out, that you really were paying attention to. So I want to go through the history of this, right? So when Wellbutrin came out in 1985, its recommended dose, we only had the IR formulation at this point. SR, XL, like SR came out several years later. XL came several years after that, right? So we only had IR. And the recommended dose was 400 to 600 milligrams a day, split 3 to 4 times a day. However, a year later, the product was completely removed from the market. Wellbutrin was taken off the shelves. You could not get it in 1986. They did some studies, tried to figure out what happened. And the reason why it was taken off was because it was causing seizures. All right. That's why. They figured out some better ways of dosing it, and the limits on how much someone could take. They reintroduced it in 1989. Now, the unfortunate thing is, fluoxetine, if you'll remember, came out in 1987. And even though Bupropion beat it to the market in 1985, because of this, it was reintroduced after fluoxetine had already kind of taken off. And then, Prozac Nation, and it was on the cover of magazines and everything. And people they had this bad taste in their mouth from what happened with the seizures with Bupropion. And so it kind of languished for years. But I mean, if you look at our top 300, it actually was ranked one ahead of fluoxetine now. So it's gained favor, and let's talk about why. So if somebody has a normal weight, for their a healthy weight, and they're taking an XL formulation of bupropion, and they have no other risk factors for seizures, then the normal dosing range up to 450 milligrams, they will have a extremely low risk for seizures. There's a 5% risk for doses over 450 milligrams, but quite a bit less than 1% if it's less than that 450 or less. So, right, remember the max dose used to be 600, and it was IR. The IR and the high doses is what causes the seizure risk. If you're using SR or XL and using lower doses, the risk is extremely low. All right. And so if a patient's on, say you have a patient that has seizures and they're taking an anti-epileptic drug, Wellbutrin's probably going to be tolerated and may help with concentration and energy side effects of that medication. So just because someone has a seizure disorder doesn't mean that you can't give this medication. I would probably be very cautious about it. But if they're on medications that's controlling it, and this was, like I said, the only thing that worked, and they've got like the concentration energy issues, it's an option. I don't know if I would go there. There's probably a patient out there that you would go there, but I have not run into them. I don't have a lot of patients that have seizure disorders either, because I work in the military system. All right. And It's also probably not the bupropion, but the bupropion metabolite that's what's causing the seizures. And like I said, there's a dose related effect. The higher the dose, the higher the risk. All right. And I got a little bit more information on seizures. All right. So it's contraindicated. This is according to the drug manufacturer, contraindicated to take bupropion when it's combined with other risk factors of seizures. So those include AV malformation, head injury, severe stroke, CNS tumor, CNS infection, hypoglycemia, hyponatremia, severe hepatic impairment, and hypoxia. Those are not common issues, but if they're out there, I would recommend not using this medication. Contraindicated with history of anorexia and bulimia. Contraindicated with abrupt discontinuation of alcohol, benzodiazepines, barbiturates, and anticonvulsants. So those are all those four classes of medication and drugs lower the seizure threshold. And so if you abruptly discontinue them, they increase the seizure threshold, making it harder to get a seizure. If you abruptly discontinue them, that lowers your seizure threshold, and so you don't want to throw bupropion on top of it when you've already increased the risk. In fact, I wouldn't recommend abruptly discontinuing any of those. You want to taper them off slowly, but the patient may have abruptly discontinued themselves. So not a common situation where someone has just done this and then you're like, oh, I'm going to start bupropion. No, don't do it. And then there's caution, so not a contraindication. Those first three were contraindications: the eating disorders, and then the medical issues, and then the abrupt discontinuation of those medications. There's caution when combining with other drugs that increase seizure risk. This includes tricyclics, lithium, some antipsychotics like the phenothiazines, the thiazanthines. So those are more the first generations. Theophylline, corticosteroids, stimulants, anorectants, and the anorectants I'm talking about are more like phentermine, not the new GLP-1s so much. Hypoglycemic agents, alcohol, and tramadol. So caution when combining with those. And then here's another thing. Whenever I was like training in my early days of psychiatry, and I was an intern, I was doing my family medicine rotations, and the physician I worked with, she was just like very much against this. She's like, these cause seizures. I don't ever prescribe them. And it's like, well, no, actually, they cause seizures at doses that are above the dosing range we have now, and they're more likely with the IR formulation. So if you're giving, like I said, if you're giving XL and you don't have seizure risk, and you have a normal weight, your risk is very low. In fact, it's lower. Tricyclics and escitalopram and citalopram actually have a higher risk of seizures than normally dosed Wellbutrin XL in a normal healthy patient. So for those of you that are worried about the risk of seizures, I've gone through the things that if these conditions are in place, then that's when you need to be concerned about bupropion causing seizures. If those things are not there, then you do not need to be worried about it. All right. So let's go through drug interactions. So bupropion is metabolized by 2B6. Not a lot of drugs are, but there are a handful of 2B6 inhibitors. Sertraline's one of them. Norfluoxetine, which is the metabolite of fluoxetine, and clopidogrel, that's a blood thinning agent. Those are the three most common. And so we often combine an SSRI with bupropion. You might not want to combine. I mean, I think fluoxetine would be the worst because bupropion is a 2D6 inhibitor. So it's going to increase the levels of fluoxetine, and then norfluoxetine is a 2B6 inhibitor, so it's going to increase the levels of bupropion. So you're kind of increasing both, right? One is increasing the other, and then sertraline, it's an inhibitor of 2B6. Probably not a very strong one, but those would maybe be the SSRIs I would be least likely to, particularly fluoxetine, because Wellbutrin inhibits its metabolism as well. So the Prozac Wellbutrin combo is probably the worst. Though, have I seen patients on this before? Sure. Have they had problems? Not really. But I mean, that can increase your risk of side effects. It can increase your risk of seizures because if you're increasing Wellbutrin's drug levels, right? And then there are some 2B6 inducers out there. So these are ones that are going to lower the drug level. So this is carbamazepine, uh, rifampicin, and ritonavir. There's a few more. So these would basically make the medication less effective, right? And then, like I said, hydroxybupropion is a potent inhibitor of 2D6 that affects fluoxetine, paroxetine, duloxetine, fluvoxamine, risperidone, venlafaxine, decipermine, dextromethorphan, right? And we actually use it with dextromethorphan, which we'll talk about later. That's Auvelity, because we want to increase dextromethorphan because that's such a short half-life, right? But you probably don't want to combine it with those other medications because then you're kind of, this is why combining it with like an escitalopram, hey, my top SSRI, it doesn't interact with bupropion. So neither one interacts with the other one. And so you can rest assured that your levels will be well controlled there. All right. So let's moving on. Now we move into my advantages and disadvantages, and I've got a lot of advantages and a lot of disadvantages. So let's talk about the advantages. And we've already highlighted a lot of this, right? So when we contrast it to SSRIs, all the stuff we don't like about SSRIs, it doesn't do those things. So it lacks SSRI-induced sexual dysfunction, apathy, and weight gain. There's a low likelihood of inducing mania in patients with bipolar disorder because we're not affecting serotonin. Also means there's a low risk of serotonin syndrome. There's still a contraindication to use with MAOIs. I don't know how concerning. I mean, actually, that's concerning because MAOIs increase norepinephrine and dopamine, and so you're not having the risk of serotonin syndrome so much when combining with MAOI, but you're maybe increasing norepinephrine and dopamine too much because they kind of increase them in different ways. So perhaps that's why it has the contraindication. Though I'm not worried about serotonin syndrome at all with bupropion. It doesn't affect serotonin, right? So more advantages. So like I said, I've given this to patients with bipolar disorder. If you're looking for an antidepressant to give to a bipolar patient to help with the depression, Lamictal's probably my top choice. Lithium, hopefully they're already on, can help. Some of the antipsychotics like quetiapine. But if you're running out of options, and a lot of people reach for SSRIs, which I would not do, bupropion might be one you could go for. I'm not sure how much it would help, but it's a lot less likely to induce mania. Though if you read, it says, "Oh, this could induce mania." I don't buy it, but um, that's my 2 cents on it. I'm not really concerned about inducing mania. I've not seen that happen before. So other advantages. So people that are partial responders to SSRIs, so you can use this as an adjunct. I talked about my escitalopram bupropion combo, right? They don't affect each other's blood levels, but they hit all three reuptakes. And so if you got a little bit of good effect with escitalopram, but not quite enough, you could add this on top. If I got nothing, of course, I would just switch. But if you get some effect but not enough, and you maxed the dose out or maxed out to what the patient can tolerate, adding this could be helpful. So this is a great add-on. You can add this to a lot of different medications because it has such a unique mechanism of action. It does things that most other antidepressants don't do. It may help with psychomotor slowing. So it's got kind of this. I think a lot of people, when they think about, am I going to give somebody an SSRI or bupropion, they think, if I've got kind of an anxious, depressed patient, I'm going more for SSRI. If I've got more of an anhedonic, unmotivated, fatigued, low energy patient, I'm going to go with bupropion. That's, I think, for those of you out there that prescribe these, that's probably your thought process. And it used to be mine. But what we're going to talk about in a second is I think bupropion can be used more than you think it can be. However, if you do have a psychomotor slowed patient, bupropion may be a good option for that patient. Because often the SSRIs can, calm you down too much, make you apathetic. So atypical depression, bupropion may be good for. Hypersomnia, so you've got somebody who sleeps too much. right? And, this can impair your ability to sleep. So that may actually be helpful for someone who's sleeping like 12 hours a day or something. Already mentioned people that have nicotine dependence. And the other thing is you can use this in combination with other things. So if you want to use it with a nicotine replacement product, that's actually a great idea, right? So maybe one was not, the bupropion helped, it got rid of some of their cravings, but they're still craving. Give them some, patch, gum, whatever. I mean, patch is the one I would prefer, but whatever, works for them. So you can combine it. And often combining is the best. Like I combine from the get-go. Like I'll give them Chantix or Bupropion, and then I'll give them a nicotine replacement product to get them through. And so when they do crave it, and so that they don't go to the cigarette. And also, I'll do patch and gum. Give them the patch, and then if they've got some breakthrough, they add the gum to it. So you could actually do patch, gum, and Bupropion. I probably wouldn't start all three at the beginning, but I would consider two. I talk to the patient. What do they want? What do they think the best options for them are? And I would often offer them two. That way we kind of cover from two angles, right? We get rid of the craving, and then we satisfy the craving as well. Okay. Cognitive slowing is another advantage. It's Another advantage is it's well tolerated. Now, I mentioned the side effects. Patients do get the insomnia, the jitteriness, the agitation, but I'd say compared to other antidepressants, when we look at TCAs and MAOIs, SSRIs and SNRIs, and I mean, how many episodes did I have on serotonin side effects? I had like six, right? How many episodes did I have on norepinephrine side effects? None. I talked about it for 2 minutes when we talked about SNRIs. How many episodes have I had on dopamine side effects? None. I didn't talk about it at all. Serotonin is what causes the majority of the side effects, right? And so bupropion does not cause those side effects, and that makes it more tolerated. Now you're going to have different patients that are more sensitive to one drug versus another. If somebody, gets the Wellbutrin side effects really strongly, but they don't get the serotonin ones, go with the serotonin medication. In my experience, on average, I think most people have more problems with the serotonin side effects. However, I don't not use those medications. Certainly, I probably use these about evenly. Especially if you're using a lower dose of the SSRIs, you're going to be much less likely to get those side effects, right? And that's the same with most medications. All right. Other advantages: there's no alpha blocking, no histamine blocking, no anticholinergic side effects. Um, it can help improve concentration, and despite beliefs, it can be an effective anxiolytic, right? I know it can make anxiety worse. So that's a side effect. It can make anxiety worse, but it can also improve it in some patients. So just because you have an anxious patient doesn't mean we say no to bupropion. So it's got the unique mechanism of action. No other medication works like this one. There's no other meds in this class. So it's not like the SSRIs where it's like, well, I could have several to choose from. The SNRIs, you have several to choose from. No, if you want to do what bupropion does, it's the only one that does it. And then fatigue. That's my last advantage. Could help with fatigue. So it's a long list of advantages, right? And I'm actually going to continue with my advantages. There was a paper that came out several years ago entitled, "Is Bupropion Your Number One Antidepressant Choice?" It's very short. It's like not even a paper. It's just kind of like an editorial. It's a couple pages of and it's big type and graphics and stuff. So I highly recommend reading this. But I'm going to highlight what this paper said. So first, in the paper, they talk about what SSRIs do. They cause weight gain. They cause sexual dysfunction. They have a long taper. They cause withdrawal. You don't get any of those issues with bupropion. And those are big issues. Those are like limiting issues for patients that they can't take the medication because of it. All right. And the next section, the author went into 3 reasons that providers skip bupropion and why they shouldn't. Okay. Reason number 1 that people skip it: they think that it won't treat comorbid anxiety and could make it worse. All right. And he gave some statistics here: 59% versus 64% compared to SSRIs for anxious depression. That's almost the same. So it helped in 59% of the time, SSRIs 64% of the time in anxious depression. That's almost the same, right? We think of SSRIs as helping more with anxious depression, but Wellbutrin is actually almost as good. 54% versus 61% compared to SSRIs for anxiety. So when compared, the first one was anxious depression, which is like anxiety and depression, and just for anxiety, no depression, 54% benefited versus 61% for SSRIs. So SSRIs did a little bit better, but it's very close, and just very, very close, and you're avoiding all those side effects of the SSRIs. So it it is almost as likely to help with anxiety as SSRIs. So that's number one reason why providers skip it. Number two is the fear of inducing seizures, and I've already gone through that. There is a 0.1% risk versus 0.08% risk compared to the general population with the SR formulation. All right, what does that mean? That means that just your baseline risk of getting seizures off nothing versus taking the SR or XL formulation is virtually the same. 0.1% versus 0.08%. There's virtually no difference, right? If you get a seizure on this medication at the dose, the regular doses on the extended release versions, it probably wasn't the Wellbutrin that did it. It was probably something else, an illness or something else. You probably were just going to get that seizure. Like, people get seizures. Just because you got it on Wellbutrin doesn't mean that Wellbutrin caused it. Okay. Um, so the incidence is very similar to just the general population risk. And there's actually only been 2 case reports of seizures associated with XL formulation. 2 ever. 2. This medication is prescribed millions of times per year, right? And only 2 cases of somebody that got seizures on it that they said was because of the XL form, that on XL that they said was because of bupropion. So, I mean, that's a pretty, really, really low risk. So if you're not prescribing it because of seizures, think again. If you're not prescribing it because this is an anxious patient, think again. And then what's the last one? Titration. Okay, this is another reason that people don't prescribe it. In the community, and not this, what it wasn't the case for me in the military. Typically the way we prescribe it is we do 150 milligrams for 3 to 7 days, and then 300 milligrams. What I would do is I would give them a 150 milligram pill, and I'd say take 1 for a week and then take 2. Well, in the community, that they just, for whatever reason, they don't allow this, and so you have to give them a 150 milligram pill, and then you have to give them a 300 milligram pill to take after that. I don't really like doing this because if they didn't tolerate, once they went up to the 300, if they didn't tolerate it, I like them to have the option of continuing with the 150. I have patients that do well on 150, and they do well on 150 forever. And they never need 300. Or maybe they don't tolerate the 300, but 3 or 4 months of taking 150, then they take the 300. For the vast majority, a week at 150 is enough to get yourself up to 300. And most patients need 300. But I like to have that flexibility. Give them the 150s so that they don't have to stop taking it. They're either going to keep taking the 300s and feel like crap, or they're going to stop taking the 300s and take 150s. Or they're going to stop taking the 300s because they don't have the 150s. And then so they're either going to be, if they didn't tolerate it, they're either going to still be on 300 feeling like garbage, or they're going to be have stopped it, and maybe the 150 was going to work, but I only gave them a week of 150s, and so they couldn't split the 300s, right? So that's why I like to give them 150s. And like I said, the military system, they allowed that. Hush hush, if I was in the community, I would say, here's 150, take 1 a day, and I'd give them 60. And they'd come back and see me in a month, and I'd tell them, hey, take 2 of these. If you tolerate it, you can go up to 2 after a week. And then they'll just run out earlier, and I'll just give them a new script. But if you, in the community, if you write, take 1 for a week, then take 2, they won't allow it. They won't allow you to give a patient 2 150s. It makes no sense. It makes no sense at all, but they don't allow it. If you say just take 1 in the script, but the patient actually takes 2, I mean, I guess I don't want to advise you to do that. I'm just throwing it out there that that's something that could be done. And I don't know why there would be a problem with it. All right. But I'm not telling you to do it. I'm telling you that that's what I did in the military, but I actually put in the script, take 2 after a week. But I told the patient, if you go up to 2 and you need to go down to 1, go back to 1. If you hated the 2, go back to the 1. I like to have that flexibility. I don't, I don't need to deal with, that they had to follow this script to the T and it just didn't work for them. I want them to have some flexibility. With a lot of pills, you can say take 1 to 2 and you have that option. For some reason with bupropion, the pharmacies or the insurance companies or whatever, they don't want you to say take 1 to 2. So it is what it is. There may be a system out there like the military where that's allowed, but so the titration can be a bit onerous because of that, but there are some ways around it. Hint, hint. So hopefully that alleviates some of your concerns about bupropion as not the first option. But let's go over what's not good about bupropion when you don't want to prescribe it. And, I've mentioned all these things, but let's kind of wrap it up. So the irritability, agitation, and the jitteriness, they get that, may not be a great choice. It can increase blood pressure. That's not great. Like I said, I might treat the blood pressure if this was the only medication that worked. The strong 2D6 inhibitor function. So that doesn't affect sertraline. It doesn't affect escitalopram, citalopram, desvenlafaxine, vilazodone, trazodone. There's several other antidepressants that you could combine it with, but you need to look and see what medications they're on. Are any of these affected by 2D6? Because bupropion can increase those levels, and that could be a problem. Most of the 2D6 medication substrates that I think of are antidepressants, but there are others out there, and so you should check that. So that might be an issue depending on what else they're taking. Could you change that medication that they're taking? Yes. Maybe you find a very similar medication that's not affected by 2D6, and then we're able to give them the Wellbutrin. Okay. Next disadvantage could worsen anxiety in some patients, but once again, the serotonin medications can also do this. All right. Next, overactivation. So this is why we want to dose it in the morning, because it can cause insomnia. All right. Concern over low weight. So if you've got a patient with an eating disorder or low weight already and they're losing, not everyone's going to lose weight that takes bupropion. If they have an eating disorder, or I suspect one, I'm not going to give them this medication. But if they're just low weight, I would not necessarily not give it to them. I'd monitor their weight. And, if they're really underweight, then I probably wouldn't. But if they're just kind of on the border, I'd give it to them and see. But I mean, this would be a time when you'd probably pick an SSRI first, right? But if you've already tried the SSRI and you want to try something different, you could still do this as an option, right? Not the eating disorder patient, but the underweight patient. But then, make sure you monitor their weight. If they're losing more weight, then we'll have to try something else. All right. Patients with a history of or higher risk for seizures, including patients with eating disorders. So that's one that's another one we need to be concerned about. If someone has tics, it could make tics worse. It's probably less likely than your stimulants to do that. And then when used with dopaminergic agents, it could precipitate psychosis. So if they're taking like a pramipexole or something like that, like a dopamine agonist, and it could, cause psychosis, too much dopamine. Could cause delirium, could cause dyskinesias, movement disorders. So, I mean, when we think about these disadvantages, most of them are either rare or we can find a way around them. The 2D6 inhibition, we can find our way around that if we pick the right medications to combine it with. The seizure risk, we can, formulate it right, dose it right. The main issues, if they're a high seizure risk, if they have seizure risk, if they have an eating disorder, those are the patients not to give it to. And then the patients to get irritability, agitation, jitteriness, insomnia that we can't get around by maybe giving them a low dose for a longer period of time. Those are the ones that are not going to be appropriate for this medication. But, I just want to, that's the end, but I want to just kind of summarize why I like this product. If you haven't already gathered, right? Because I want to take into what I've kind of talked about with placebo, right? Most of and like I said at the beginning, I like treating bipolar, ADHD, schizophrenia because the drugs work a lot better. The meds for depression don't work that great. They are all mostly placebo, and they're all very similar. I mean, there's some treatments like ketamine and ECT and TMS which work quite a bit better than our other treatments, but those are not available to most patients, right? The treatments that are available to most patients, the treatments that the PCMs are giving, they all have relatively equal effect, right? So whether it's an SSRI, an SNRI, an NDRI, or whatever it is, they all have TCA. They all have relatively similar effect size. Now, that doesn't mean that one patient is not going to respond to a treatment better than another treatment. There's often no way to really know what patient will prescribe will do well with one medication or another. But on average, they're all pretty similar. Okay, and so when I'm thinking about picking my antidepressant, and I think what you'll notice in my whole lecture series that I'm doing, especially when we talk about antidepressants, is I'm not talking about how great they are. I'm taking more of a pharmacy approach here. I'm telling you what to look out for. I'm telling you about side effects. I'm telling you about contraindications, dangerous syndromes, QT prolongation, or sexual side effects. I'm telling you about the downsides because that's mostly what you need to be concerned about. The upsides, they're all pretty much the same for that. They're all very similar. Maybe you've got this type of patient, a little more fatigue. I mean, and I'm going to go through, I'm going to have another lecture where we talk about, how to pick. We've gone over all the meds, when would you pick one versus another, kind of as a summary. But that's very subtle. There's a very, very subtle difference between when if they have this particular issue, I would avoid this medication, etc. It's mostly about avoiding. It's mostly about the side effects. It's not necessarily about the positive effect. And so if on average, and I don't know which drug is going to work best for which patient, like if I did, I would pick the right one. But since it's very hard to know that, I'm judging the medication I'm picking more on the side effects I'm trying to avoid. That's more when I'm going with this, right? And in my personal opinion and in my clinical experience, patients tend to tolerate bupropion better than other medications. And they tend to hate the side effects from other medications more than they hate the side effects from bupropion. Okay? That's why I pick bupropion. It's not because I think it's a better medication or it's more effective. I think they're all about the same, right? They're all about the same when it comes to how effective are they. But when it comes to how much does a patient want to take it, I find that patients prefer taking bupropion over other options more often. And that's why I think a lot of people, they pick this medication second. That SSRIs are the first line. SSRIs have so much baggage on them. If I don't have a reason why I would pick an SSRI over or bupropion, and I often do. Often I have a reason why I would want to go with an SSRI first. But if I do not have that reason, if I'm kind of like, well, either one, but I'm going to pick an SSRI first because it's always first, and this is second because it's always second. No, no, no. If I've got that type of patient, I'm probably going to pick this one. I'm probably going to pick this one because I'm guessing that the side effects are probably more tolerated. The other thing is I'm presenting this to the patient. I tell them these are our options that I think we could go with first line for you. Like based on talking to you, based on what I'm hearing, these are our 2 to 3 choices that I think we have. And this is what, like, I think they're all probably equally likely to work. I don't necessarily think that one is more likely to work than another. One may work better than the other, but I have no way of knowing what that is until we use them. However, you're much more likely to get these side effects from this med, these side effects from this one, and these from this one. And I say, which one would you like to pick? And they often will pick this one because when they hear what the side effects are from other medications and this one, I think they're thinking, oh, and then when I tell them it may even help with concentration, everyone thinks they have ADHD. And so if I say, this could actually benefit some of those symptoms, even if you don't have ADHD. So for many reasons, patients tend to pick this med. And like I said, because the effectiveness is so similar, This is why I like this one. But I always give patients a choice. I say these are the ones that I think we could go with. Which one do you want? So I hope that you enjoyed this talk on bupropion as much as I have, and I hope that if you maybe were not going to prescribe it that much, and maybe you didn't think about it quite that much, I've given you at least a couple of reasons. Maybe you're thinking about the nicotine. Maybe you got a patient vaping, and you're like, hey, this might help with vaping. Great. So maybe you've heard, maybe you weren't convinced by my overall argument, but you heard a couple of points here and there that kind of said, oh, maybe for that patient, maybe for that patient. I didn't think about that. Or, oh man, I didn't realize that I shouldn't give it to that patient. That's what I'm hoping you get out of this. Unfortunately, I can't tell you what's the most effective because they're all about the same. What I can tell you is how to safely give these medications to patients, what to look out for. If you see certain things happening, that you'll be aware that this can be caused by this medication, and that I've given you what to. It's not just stop it. There's ways to treat it, right? I'm trying to help you to safely and effectively give these to patients, to give them the most likelihood of success and the least likelihood that they're going to hate it and stop it and not take it and maybe not even tell you about it, right? So thank you so much for joining me. The holidays are coming up. I may miss a week here or there. The next medication that I'm going to cover is going to be mirtazapine Remeron. This is another unique medication. So I hope you're excited for that one, and I'll see you next time.